Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the neurology, that is trigeminal neuralgia. So I'll just give you a clinical scenario of how the presentation of a patient with trigeminal neuralgia will be. So a patient presents with recurrent episodes of sharp pain over his right cheek that is precipitated on chewing. Between attacks, the patient is otherwise normal. What is the most probable diagnosis? Preherpetic neuralgia, trigeminal neuralgia, mumps, and then thalamic syndrome. So this is a case of trigeminal neuralgia. So in patients with trigeminal neuralgia, they have recurrent episodes of sharp pain. And most commonly they are present over the right cheek. That is, mostly the pain will be unilateral. And this pain of trigeminal neuralgia gets precipitated on chewing. And between the episodes, the individual is otherwise normal. Now, if you see the epidemiology of the trigeminal neuralgia is a rare condition that affects women more than men. Right? It is more common in women rather than men. And the incidence of this trigeminal neuralgia increases gradually with age of the individual. Right? Incidence, it increases with the age of the individual. And the most common age group, right? The most common age group at which you see this trigeminal neuralgia is around 50 years. Right? It is around 50 years. And if you take the etiology and as well as the pathogenesis of trigeminal neuralgia, most cases of trigeminal neuralgia, they are caused by compression of the trigeminal nerve root. Right? So most cases, they are caused by compression of trigeminal nerve root. Okay. And where is this particular trigeminal nerve root? It starts all the way from pons, right? And it progresses down to the medulla and as well as the upper part of the spinal cord as well. So most cases of trigeminal neuralgia are caused by the compression of the trigeminal nerve root. And this compression of trigeminal nerve root, it is usually within a few millimeters of entry into the pons. And this particular compression of trigeminal nerve root, it is by an aberrant loop of an artery right? It is by an aberrant loop of an artery or vein, right? Aberrant loop of an artery or vein. And this compression by aberrant loop of an artery or vein is thought to account for 80 to 90% of cases, right? So this aberrant loop of an artery or vein compressing the trigeminal nerve root, it is seen in almost 80 to 90% of the cases, right? So that is about the etiology of the trigeminal neuralgia. And at the same time, you need to know what are the clinical manifestations of the trigeminal neuralgia. See, trigeminal neuralgia, it is defined clinically by paroxysmal, stereotyped attacks of usually intense, sharp, superficial or stabbing pain. Okay, so the episodes, they are paroxysmal in onset. That means they appear suddenly. And how will be the episodes? The episodes are intense, right? They are very sharp, right? They are very sharp, superficial or stabbing pain. Right? So this will be the character of the pain in case of trigeminal neuralgia. And this pain, it is present in the distribution of one or more branches of the trigeminal nerve. Right, it is present in the distribution of one or more branches of trigeminal nerve. That is what is the character and distribution of the pain of trigeminal neuralgia. And this particular pain of trigeminal neuralgia, it tends to occur in paroxysmal and it is maximal at the onset of the pain. Right, it is maximal at the onset. And this particular pain, the pain is so severe, and along with this pain, there is also facial muscle spasms. Right, there is also facial muscle spasms. So facial muscle spasms can be seen with the severe pain of the trigeminal neuralgia. And one of the old terminology of trigeminal neuralgia is the tic dolorox. Right, one of the old terminology of trigeminal neuralgia is tic dolorox. And the pain of trigeminal neuralgia, how is that the individual will feel is, it is often described as electric shock-like sensations. Right, it is being felt as an electric shock-like sensation. And what will be the duration of this pain? The duration of this pain of trigeminal neuralgia, it will last from 1 to several seconds. Right, it lasts from 1 to several seconds. And it will occur recurrently or repetitively. Right, it occurs repetitively. That is what is the pain of the trigeminal neuralgia. And where exactly is the distribution of the pain? The distribution of the pain most often involves unilateral. And it is most commonly on the right side than compared to that of the left side. Right, it is more common on the right than compared to that of the left. And occasionally the pain may be, right, occasionally the pain may be bilateral as well. Right, though rarely on both the sides, occasionally it can be bilateral as well. And the distribution of the pain most often involves the second branch of the trigeminal nerve. So trigeminal nerve, which is a fifth nerve, you have 5-1, that is ophthalmic branch. And then you have 5-2, which is nothing but maxillary. Then we have 5-3, that is mandibular. So now, where exactly is the distribution of the pain most commonly? The distribution of the pain most often involves 5-2. Right, most often involves 5-2. And then followed by that, the distribution of the pain is across 5-3. Right, distribution of pain most often involves 5-2 or 5-3 subdivisions of the trigeminal nerve. So this will be the distribution of the pain in case of trigeminal neuralgia. Now followed by that, you also need to know what are the triggers of the trigeminal neuralgia. Right, what is the triggering event of trigeminal neuralgia? Let me tell you, a gentle touch, that is lightly touching these zones, often triggers an attack. Right, lightly touching these zones, that is either ophthalmic, maxillary or mandibular division, will trigger an attack. Right, leading, so one important trigger is your light touch, and other triggers are right? Other triggers of trigeminal neuralgia, it includes chewing, then talking, brushing the teeth, exposure to cold air, smiling, and then grimacing. So, right, grimacing is like the abnormal facial expressions. So these are the triggers for the development of or for an attack of trigeminal neuralgia, right? So unlike some other facial pain syndromes, the trigeminal neuralgia typically does not awaken the patient at night. You take the pain of cluster headache. The pain is so severe that the individual gets awakened during the sleep. Whereas in case of trigeminal neuralgia, the pain does not awaken the patient at sleep. Okay. Now, followed by that, these patients with trigeminal neuralgia, along with this electric shock like sensation pain, the individual also has the autonomic symptoms. The autonomic symptoms, they are mild to moderate. Right? Autonomic symptoms are mild to moderate, and they can occur in association with attacks of the trigeminal nerve in the 5-1 trigeminal distribution. So, across which particular distribution you have this autonomic symptoms? That is across ophthalmic division of across ophthalmic division of the trigeminal nerve, you have the presence of this autonomic symptoms, and these particular autonomic symptoms include lacrimation, then conjunctival injection, that is redness of the conjunctiva, then followed by that rhinorrhea. So these are the autonomic symptoms that you will have in the trigeminal neuralgia, and they are most commonly distributed across the 5-1 division. And the most common division of trigeminal nerve involved in trigeminal neuralgia is the maxillary division, then followed by that mandibular division. So you have to understand one important point here. Autonomic symptoms most commonly ophthalmic division, but features of trigeminal neuralgia, that is pain, it is more common across, right? It is more common across the maxillary division, then followed by that the mandibular division. Now, how will you diagnose these patients of the trigeminal neuralgia? The diagnosis of trigeminal neuralgia is based upon the characteristic clinical features which I have described above, right? So, the symptomatology itself tells you that it is a case of trigeminal neuralgia. So, history is very important. Then followed by that, once the diagnosis of trigeminal neuralgia is suspected on clinical grounds, right, once the diagnosis is suspected on the clinical grounds, then you have to search for secondary cause, whatever is causing the compression of the trigeminal nerve root. Okay, then you have to search for you have to search for the secondary cause. Okay, right. How will you search for the secondary cause? In which you need to do MRI or the CT brain, right? In which you need to do MRI or CT brain. And this trigeminal neuralgia, we have another name for this. This is also known as the suicide disease. Right, this is also known as the suicide disease. This is another name for the trigeminal neuralgia. Now I'll just show you a question on the same topic. All of the following statements about trigeminal neuralgia are true except most commonly involves ophthalmic division of the trigeminal nerve, attacks most commonly occur during the day, affects women more than men, and more common on the right side. So the one which of the following is incorrect statement. So let me tell you, most commonly involves ophthalmic division of the trigeminal nerve is an incorrect statement. It most commonly involves the maxillary division of the trigeminal nerve root. And attacks most commonly occur during day is a true statement, and it is more common in women rather than men, and it is more common on the right side rather than the left side, and occasionally it can be bilateral as well. Now if you see the treatment of trigeminal neuralgia, drug of choice for trigeminal neuralgia is chlorpromazine, carbamazepine, gabapentin, fluoxetine. Drug of choice for trigeminal neuralgia, it is the carbamazepine. Carbamazepine is an anti-epileptic drug which we give in the treatment of the focal epilepsy, and that carbamazepine is considered to be the drug of choice. Okay, so the medical management, if you see, it is carbamazepine. And for suppose if the individual is not responding to the carbamazepine, the next alternative like what we have is the oxcarbamazepine, right? So the medications most helpful for the treatment are the oxcarbamazepine or carbamazepine. But whenever you are giving this oxcarbamazepine or carbamazepine, what is that you need to monitor? Right? You need to monitor the serial blood counts, right, which gets altered whenever you are giving this carbamazepine or oxcarbamazepine, right? And you need to do the liver function test, where there can be derangement of liver function test when the individual is on carbamazepine particularly, right? For suppose if these medications are ineffective, right, carbamazepine and as well as oxcarbamazepine, right, for suppose if they are ineffective, then phenytoin should be tried, right? If they are ineffective, then phenytoin should be tried. Now apart from these, what are the other medications that you have to give for trigeminal neuralgia? The other medications that can be given is baclofen, right? And this baclofen should be given at a dosage of 10 to 20 milligrams. You have to give through the oral route, and it has to be given thrice daily. And the another important drug will be topiramate, and this topiramate, it is an anti-epileptic drug, right? It is an anti-epileptic drug, and this topiramate, it is given around 50 milligrams twice daily. And last, like what we have is lamotrigine, right? Lamotrigine, and this particular lamotrigine is given 400 milligrams orally, right? 400 milligrams orally. So these may also be helpful either alone or in combination with one of these agents should be given. So these are the other agents, but the drug of choice will be your carbamazepine. And we have one more drug that can be given in patients with the trigeminal neuralgia, that is gabapentin. So even this gabapentin will relieve the pain of the trigeminal neuralgia. And especially in patients who do not respond to conventional medical therapy, not responding to carbamazepine, not responding to phenytoin, right, not responding to the baclofen, then you can give this gabapentin. Okay, so depending upon the response and tolerance, right, depending upon the response and as well as the tolerance, the dosage of the gabapentin you can give up to 3600 milligrams daily, right? And you have to give this through the oral route, right? And it is given in divided doses, orally in divided doses. Now coming to the surgical treatment. So surgical treatment, if you see, in which group of individuals we will give this? Trigeminal neuralgia patients who are refractory to medical management. Right? Trigeminal neuralgia patients who are refractory to medical management, in them you need to do the surgical treatment. Right? Several surgical treatment options are available that provides the initial pain relief in at least 80% of patients. And the surgical treatment options which are available is, number one, microvascular surgical decompression. Right? Microvascular surgical decompression. So what you will do here, microvascular surgical decompression is separation of the anomalous vessel from the nerve root produces long-term relief of symptoms. Right? So microvascular surgical decompression from the anomalous vessel right? So when you do this, that will provide long-term relief of symptoms. Right? Long-term relief of symptoms. So that is what is the surgical treatment in patients with the trigeminal neuralgia. And there are three less invasive techniques based on the destruction of nociceptive trigeminal nerve fibers. Right? Three less invasive techniques. They are based on destruction of nociceptive trigeminal nerve fibers, which causes the sensory loss in addition to symptom relief in half of the patients. Now, what are those three less invasive techniques? These three less invasive techniques include, number one, radiofrequency rhizotomy. So this radiofrequency rhizotomy produces long-term pain relief in up to 60% of patients. Right? So this will produce long-term pain relief in almost 60% of patients. And second important thing is percutaneous balloon compression of trigeminal ganglion. Right? Percutaneous balloon compression of trigeminal ganglion. So this percutaneous balloon compression of trigeminal ganglion will cause pain relief in almost 67% of patients. Then followed by that stereotactic radiosurgery to the trigeminal nerve root. Right? Stereotactic radiosurgery to trigeminal nerve root. Right? To the trigeminal nerve root. So these are the three less invasive techniques which will cause, the basic principle is they cause the destruction of the nociceptive trigeminal nerve fibers, which causes the sensory loss in addition to the symptoms relief in half of the patients. Now, what is the preferred procedure in elderly patients? In elderly patients with limited life expectancy, radiofrequency rhizotomy and stereotactic radiosurgery are the preferred methods. Okay, so one is your radiofrequency rhizotomy. right? Radiofrequency, rhizotomy, and stereotactic radiosurgery. Right, stereotactic radiosurgery. So these are sometimes preferred because both can be performed without general anesthesia and they have very few complications. Right, both of them can be performed without general anesthesia, right, and they have very few complications, right. And surgical exploration is inappropriate in patients with trigeminal neuralgia due to multiple sclerosis, right. If the trigeminal neuralgia is there due to multiple sclerosis, surgical treatment should not be done. Okay, so the preferred procedure in elderly individual is radiofrequency rhizotomy and as well as stereotactic radiosurgery. So this completes the treatment of the trigeminal neuralgia, right. So you see this image, right. So this is your radiofrequency needle with which you can do the rhizotomy. So finally, the drug of choice for trigeminal neuralgia is what? That is carbamazepine, right. So these are some of the very important points related to this topic of trigeminal neuralgia. Thank you very much.